Okay, so now we are going to look at neonatal jaundice. Neonatal jaundice is a condition in which there is increased bilirubin and yellow discoloration of sclera and mucous membrane. So when bilirubin exceeds more than 5 milligram per deciliter, neonatal jaundice develops. Now, neonatal jaundice is 60% common in term babies and 80% in preterm babies. So, in neonatal jaundice, there is hemolysis happens in reticuloendothelial system. Heme is converted into bilirubin, and then in serum it goes down into the brain and cross the blood-brain barrier, and then it causes different problematic conditions. Now, risk factor for developing hyperbilirubinemia, excessive bilirubin in the blood, are if there is blood type AB or RH incompatibility in maternal factors, breastfeeding mothers have risk of developing hyperbilirubinemia, gestational diabetes mothers are torch infection in neonatal uh, include uh, risk factors include birth trauma, cephalohematoma, bruising, or instrumental delivery, infrequent feeding, excessive weight loss after birth. Male gender have more common occurrence of jaundice, and in prematurity, neonatal jaundice occurs. Evaluation of yellow baby is we will have to take the maternal history to exclude the maternal causes like torch infection, or if baby is preterm or term baby, then neonatal jaundice can be developed. Our feeding history is also there. If baby is taking other milk out of mother feeding, then those babies have chances to develop jaundice. Now, obstetric history of mother is also evaluation criteria. Family history, visible wasting with Okay, physical examination includes jaundice has cephalocaudal progression from face to neck and then upper trunk, lower trunk. So we will have to exclude in physical on the basis of physical history, and then we will also look for bruising, swelling, cephalohematoma, macrosmia. Maternal diabetic mother have more common in babies having macrosomia, pallor, petechiae, signs of dehydration, and hepatosplenomegaly or hemolysis are also finding points of neonatal jaundice. Hyperbilirubinemia common causes are physiological jaundice. It is breakdown of excessive fetal hemoglobin and immature uptake by liver and increase in enterohepatic circulation. That is physiological jaundice that occurs on the second day of delivery. And another one is breast milk jaundice, which is glucuronidase or non-esterase fatty acid in breast milk compete with the UDP glucuronide transferase, that is known as breastfeeding jaundice. Another one is pathological jaundice, which occurs because of ABO incompatibility, RH factor, GDP, or thalassemia, torch infection, or hypothyroidism. So in this chart, we can look at the risk of hyperbilirubinemia increases with postnatal age, and high risk is at 90% of life. So red flags that needs urgent referrals are jaundice on the first day of life, pathological jaundice, or there is jaundice persists beyond 2 weeks of the age. Lethargic babies have also pathological jaundice as well. So in this